sir. Now it is an honor and privilege to introduce one of the most esteemed sessions of TOSACON 2025, that is Professor VSN Murthy Oration. Professor, screen. Yeah. Professor Dr. Vedula Satyanarayana Murthy was born on 15/2/1951 at Kottapeta, East Godavari district. He was the fourth son of Sri Venkat Rao Garu and Srimati Lakshmi Kantama Garu. His primary schooling was at Kottapeta and he admitted in MBBS at Andhra Medical College, Vizag in 1967, post-graduation in orthopedics at AMC Vizag. He joined as assistant professor of orthopedics at KMC Varangal in 1978 and remained in Varangal. He was promoted as professor of orthopedics in 1995. He is selfless, dedicated, committed orthopedic surgeon. He used to work in hospital round the clock. He trained so many undergraduate students and postgraduate students. He is a perfect disciplinarian and true gentleman to the core. He conducted various polio surgeries, tumor surgeries, apart from trauma during his service. He introduced THR to MGM Hospital, Varangal. He is the person who started Mayer's muscle pedicle grafting procedure at Varangal and produced number of papers in both state and national conferences. He is a great social worker involved in RSS activities in the town. He is the first person in the state to do titanium prosthetic hip replacement and in pelvic surgery. He used to attend all national and state conferences and national CMEs at various places, and he was awarded the Best Participant Award at Indore National CME. In 2001, he was diagnosed with primary hepatocellular carcinoma, for which he underwent hepatic transplantation at England. After returning from England, he resumed his services and conducted all major orthopedic surgeries as before. He left us on 30/3/2003 with pulmonary secondaries. It is my distinct honor and privilege to introduce our esteemed speaker for Professor VSN Murthy sir oration. Today we have with us a personality who embodies the very spirit of this oration, a visionary, a trailblazer, and an inspiring thought leader, Professor Rajasekharan sir. Sir, please come on to the dais. Professor S. Rajasekharan sir doesn't need any introduction to this hall, but so you have n number of achievements by him where this day is not enough to read about him. And to start with, he He is MS Orthopedics, Madras Medical College, Chennai in 1987, and he has completed FRCS Royal College of Surgeons, Edinburgh, 1989, FRCS Royal College of Surgeons, London, 2009, MCH University of Liverpool, UK, 1990, PhD, the Tamil Nadu MGR Medical University in 2000, and chairman of the Department of Orthopedics, Trauma and Spine Surgery at Ganga Hospital, Coimbatore, India, and largest orthopedic specialty in South Asia with 650 beds and 35 operating theatre, performing more than 30,000 major surgeries per year. Outpatient strength is in excess of 50,000 new patients, and total outpatient attendance is around 150,000 every year. So he was President Asia Pacific Spine Society 2021 to 22. He was a Chair AO Spine International Board 2018 to 2020, Chair AO Spine International Research Commission 2015 to 17, President of CICOT 2016 to 2018, and President Cervical Spine Research Society Asia Pacific 2017 to 18, President of Indian Orthopedic Association 2011 to 12, President of Association of Spine Surgeons of India for 4 years, that is 2008 to 2012, President of International Society of Study of Lumbar Spine, Canada, 2011 to 12, President of World Orthopedic Concern, UK, 2005 to 2007, Hunterian Professor of the Year 2011 to 12 by Royal College of Surgeons of England, Distinguished Visitor to Harvard Medical International, Boston, USA, Grand Rounds Lecturer of Dartmouth University, USA, and Mayo Hospital, USA, Adjunct Professor of Orthopedic Surgery, Tamil Nadu, Dr. MGR Medical University, Member of Faculty of Medicine, Annamalai University, Member of Planning Board, Bharatiya University, the National Board of Examinations. He is an examiner for the National Board of Examination, New Delhi, and D.Y. Patil Deemed University, Pune, and National University of Malaysia, Kuala Lumpur. So, contribution to the literature, n number of literatures by him. Dr. Rajasekharan has 466 publications in international journals, 103 national publications, 85 chapter publications, 600 international and 610 national presentations. International journal positions, he acted as a Editor-in-Chief, Indian Spine Journal, Deputy Editor of the Bone and Joint Journal, USA, Deputy Editor of Journal of Spine, USA, Deputy Editor of Global Spine Journal, USA, Deputy Editor of Spine, past Deputy Editor of European Spine Journal. Research Awards, North American Spine Society Outstanding Research Award consecutively for 4 years, 2019, 20, 21, and 22. ISSLS Prize for Best Spine Research for 6 years, that is 2004, 10, 13, 17, 2023, and 2025. ISSLS Best Paper Award for Clinical Science 2021, Asia Pacific Orthopedic Association Best Presentation Award, Infection Category 2021, CICOT Research Award 2021, Best Basic Science Paper, Asia Pacific Spine Society Best Clinical Research Award 2019, Asia Pacific Spine Journal Award for Best Clinical Paper 2019, Asia Pacific Spine Society Basic Science Research Award 2019, Asia Pacific Spine Journal Award for Best Basic Science Paper 2019, Eurospine Open Paper Award 2008, McNabb LaRocca Research Award of ISSLS in 2005, Sofamer Danek Award for the Best Scientific Presentation internationally by International Society for Study of Lumbar Spine, thrice for years 1996, 2002, 2006. So these are very few in number, so many more to, sir, I request you to kindly deliver oration on the name of Professor V.S.N. Murthy. So then we'll go on. on that side, sir. You have given PPT, sir.
Good morning to all of you. At the outset, I would like to thank TOSACON and the leadership for giving me this honor and privilege to deliver this oration on a person none other than Professor Dr. V.S.N. Murthy. As you saw his biodata being read, it was very obvious that he is one of the surgeons who was a role model. A good clinician, a brilliant academician, and whether he was posted in the medical college or in the periphery, he brought many firsts, many important surgeries which he brought to the region for the first time. Apart from all this, he was a great humanitarian and also was a great teacher. And it's my really a proud privilege and honor to be delivering this oration. Thank you very much for this opportunity. Now, I chose this topic of medicine is changing, should doctors also change? Because this is one of the hottest topics that is going on in the social media. I would also like to say that this is probably a lecture for the young surgeons over here, because they are going to walk a path which is more challenging than the path that the seniors have, all of us have tread upon. The change that the world is undergoing, the medical profession is undergoing, is far rapid than anything else. And this is going to make them a big challenge in their lives. As the Upanishads and Vedas have said, there is only one unchanging truth in this world, and that the change is inevitable. So this change is inevitable, but many of these changes can be for the good, and some of them can not be so good. In the field of science of medicine, there has been excellent changes which have brought us great benefits. Now, if you see the operating theatre of many years before, many centuries before, and the present operating theatres, I mean, we are working in an environment which is high-tech, a lot of paraphernalia, and high safety. And the modern surgeon is really a high-tech surgeon who can bring great benefits to the community. This we have seen in every field of specialty. Now, if you have a completely amputated part like this, I mean, before it had to go into the waste, but now it is possible that with modern technology and techniques, that these could be replanted, and these people can have not only a salvaged limb, but a fully functional limb, bringing them back to normal. For people who are suffering with even the activities of daily life, modern medicine, surgery, and technology and processes has given them mobility and restored back their self-esteem. Gross spinal deformities like this, and if they are syndromic or because of neurofibromatosis, where the pediphyseal morphology is very low, would be a challenge and danger to operate. But with intraoperative navigation and also spinal cord monitoring and many big advantages, surgery has become safe and we can restore them back to normal. Even in the challenging field of oncology, a patient like this who has a recurrence of tumor would normally have to have a hindquarter amputation before, but now it is possible for us to remove the entire bone along with some compartments which are involved, and restore the whole femur so that she can have a total femur replacement and still lead a very useful life and go. Young children whom when we were residents were always given amputation is now completely changed. You can have an endoprosthesis and you can see that these children again are completely back to normal. So orthopedics, the change in the science of orthopedics, the change in the advancements of medicine has really brought a lot of change over here. In the field of diagnostics also, we have improved quite a lot. If this was the way we looked at brain, MRI brought a giant leap in our understanding. But then DTA actually made us look not just at the tissue, but actually looked at the fibers and the tracts properly. And it was possible for us to look at individual tracts in the spinal cord and see how they were affected, and we could actually do. T2 relaxometry and other modern sequences allowed it to look at water content, collagen content, and proteoglycans separately. And so this was not tissue radiology, but it was actually getting more into that. And now with magnetic resonance spectroscopy, we can not only look at tissues, but we also actually look at 14 different molecule contents inside the disc. So these are all very important changes that have happened that have empowered the modern surgeon into greater heights into which he can benefit his patients. So as never before in the history of medicine, we are able to diagnose and treat patients to greater levels of safety. We have safer implants, we have safer and more advanced techniques, safer technology. Our incisions and surgical trauma have become lesser, hospital stay is shorter, and outcomes are better. So, if you look at it, we should now be the most popular persons in the society. We were looked at as the most friendliest person in the society, and many of the patients considered the doctors as God. And with all these advances, we should be looking at a higher level of pedestal in the society. But unfortunately, if you see the actual truth, something has changed and something has taken a different route. And many times like this, it is very common that the doctors have to go on the roads, they have to go to the government, they have to go to the officials to give them protection. And there is some reason why the society, which actually benefits the most from the advances in medicine, is slowly changing against the doctors and the medical profession. Now, lots of reasons have been told for this. It is that there is a gap between the patient's expectations and delivery, that there is a poor infrastructure in many of the peripheral hospitals, and that we are not able to meet the demands. But this cannot be entirely true, because even in very advanced countries like Australia and the United States, where the advances are really very high, we still find that there is a dramatic increase in violence and dissatisfaction against the medical profession. So as this New England Journal of Medicine article quoted, from an unquestioned God to accountable workers is a long way for the medical profession to fall in a few short years. Now, this is exactly what I want to tell the juniors. Is this a change that we want? We have to question ourselves, why is this change? And also ask whether this change can be reversed. I think it should be reversed because the practice of medicine is very exacting. It's very strenuous, and it can be done only if it is pleasurable. If it becomes stressful and if it becomes too demanding, then the practice of medicine is going to be difficult. And the onus is on us also to take the responsibility to reverse this change. Now, the practice of medicine, the most important question, is it a practice of art or science? Is medicine an art or science? For many centuries, medicine was practiced as an art. There was not much evidence based into it, and that was wrong. That was not the way to practice medicine. And so naturally, there was a big swing of the pendulum that we should be more scientific, and we brought evidence-based medicine into that. But somewhere around the way, we became very scientific, we became too technology based, and somehow the art of medicine, the art of communication, the art of connecting with the patient, the art of feeling empathy towards the patient is slowly lost. As William Osler long ago addressed this question, he said the practice of medicine is an art. It is not purely a science or trade. It is a calling, not a business, a calling in which your heart will be exercised equally with your head. I think as young surgeons whom are going to practice medicine for the next few decades, it's extremely important to know this. Because more and more the education, more and more the conferences, more and more the lunch symposia and all the workshops are slowly taking the young mind to make it more technologically driven rather than towards the art of medicine. So as a modern doctor, what we have forgotten is the art of medicine. Now this is something which was many years ago. And I can easily relate to it because I am a third generation doctor. My grandfather was a doctor, my father was a doctor, and my son is a doctor. So we are four generations practicing in completely different circumstances. Now, whenever I used to go for my summer holidays to my grandfather's place, he always used to allow us to sit in the corner of his clinic, which was a very small room. And there was a very large area in front of his house where patients will come. And all of them were given cold water when they came because in Trichy it was very hot. He would see everybody, talk to them for a long time. And I always noticed that he knew most of them by name. And they used to discuss not only medicine, they used to also discuss something more about the families. And he used to offer them something more than medicine. And they used to bring him not only fees, but also lots of presents and their vegetation, their cultivation, whatever was growing there. And their relationship was not just medicine, it was a connect of heart to heart. The same was with my father, and I have noticed many patients coming to my father for asking many different things. And they used to bring young children at home so that my father will advise them on different aspects of this. This is all slowly changing. And what has happened is that the relationship now is not just between the patient and doctor, but so many other things are coming. Corporatization of the medicine is happening by hospitals, there is industry, there are a lot of government rules, insurance is coming, and with all these, the patient's stature is actually shrinking and shrinking. In fact, the doctor's importance also is shrinking. That's the most important thing. If we don't fight against it, we'll find that we are becoming a small speck in the environment. The industry is becoming bigger, the insurance is becoming bigger, and when this happens, the patient's interest slowly drops away. If we do not fight the change on depersonalization of medicine, if we do not fight the change where there is a slow but sure evaporation of the human element between the doctor and the patient, and allow trade and technology and industrialization to come in between, the person who is going to suffer most is us. Because for the patient, it is one-time sickness. But for the doctor, it's an everyday profession to see patients. And we are going to suffer most. If we adopt our profession as a science and not an art, and look only at knowledge and technology, then the greatest losers will be ourselves. Now let me explain a little more. Capacity for information and knowledge is already insignificant, will become more insignificant in the next few decades. When I was in school, the cleverest person was the person who could tell 16 mathematics tables very fast. If he could tell 18, he was considered to be a great wizard. If he could do mental mathematics, he was considered to be the school pupil leader. No longer after the calculators came. Sadhguru used to say that in the olden time, the parameters of leadership are changing. Now, if you were the strongest, heaviest, and tallest person in olden times, you were the king. But if you're the same now, you will get a job as the chief security officer. Because strength of physical strength is no longer valued. The dynamics of leadership and appreciation are completely different. So the same is working and will work with doctors. Knowledge of medicine, knowledge of data, knowledge of classifications, knowledge of all the history is all not going to be really big, because information and knowledge will be free and available to everybody. It is going to be a great level equalizer. It doesn't matter how much fast you can read, how much more you can memorize, how much more you can retain, because at the end of your tip of your fingertip, if you have a handheld mobile phone, every single knowledge is going to be available to all. From chess to medicine, the large language models, learning models are coming in. Now, look at this. ChatGPT, Gemini, and DeepSeek are there, and they have every single information that a doctor needs to know, or the same information which the patient also can know. So yesterday evening, I put these questions to the ChatGPT, and you will be very surprised that the patient can also do this, and he gets the real information what a doctor can give him. So I am not sure whether we can give him anything. So if you ask a question, I am a 30-year-old male having frequent episodes of low back pain. MRI shows disc prolapse at L4-5. What will be my treatment? It gives a very good discussion about all the options available. And this is the same thing that we are going to discuss with the patient. And if you want to know more about, if you click on that, it gives you more elaborate discussion on what are all the alternative therapies and this. Now to Gemini AI, which is the Google's large chat. I asked this question. I am a 40-year-old male, has had a L5-S1 disc removal surgery 1 year ago for left lower limb pain. Now for the last 1 month, I am experiencing the same pain, no weakness. What will be my treatment? It is just exactly telling you what a surgeon will exactly discuss with the patient. Now to the DeepSeek, I actually went into the other side of the question and asked, as a surgeon, what should I discuss with the patient who has myelopathy at C5-6? It actually tells you exactly what should all be the counseling and discussion should be here. Now this is going to be a game changer. No longer we have the leadership, we have the autonomy of knowledge. It is not just our domain, because whatever is known to you, or even much more than what is known to a one single doctor, is going to be known in the domain, and that is available for you, for any other doctor, for the doctor who got gold medal in the university exams, and for the doctor who failed after 4 times. Knowledge is now going to be equal, and it is also going to be available to the patient. So every decision will soon become documented and accountable. The patient can ask you, what is the basis of your decision? Now in the 2020s, every decision of the computer had to be supervised by the doctor, but you can be very sure that in the 2030s, every diagnosis and decision of the doctor has to be approved by the computer. It is already there. In most of the Western hospitals, when you prescribe a medicine on your tab, immediately it is checked, and on the dosage, whether it is appropriate for this patient, whether there is a drug interaction, and all this is well known. So these availability of big changes are going to put a big challenge to all of us. So we should no longer think that we are the domains of knowledge. This is a big change. During COVID, we started expert orthopedic opinion, and we were very pleasantly surprised that we had patients asking our opinion from all over the country, from Bangladesh, Malaysia, everywhere. And we thought it's a big advantage. But we also came to know that once you give an opinion, the patient next day was getting another opinion from the Cleveland Clinic in USA and Mayo Hospital also. So you see now, the modern things opens the world to you, but it also opens the world of a competition to the patient. So the world can be your market, but the world will also now be your competition. And what is the most important thing is, with the availability of data or knowledge to both the doctor and patient, you don't have a superiority on the patient over knowledge by ways of knowledge. 2, the young surgeon should not think that technology is his everything and it is going to give him everything. Because technology, after some time, will trump and supersede human skills and it will replace years of training. Now, all of us know these new kids on the block, the robots which have come of different kind and of different generation. And these have brought two big changes. For the younger mind, we were discussing this even in the breakfast this morning. If a young surgeon sells himself to the patient on the basis of technology, he has to realize that the patient will respect technology more than him. Patient will lose the respect for the doctor. If you say, I am the guy who is going to be superior than another person because of a robo which I got yesterday, the patient thinks that you are not great, the robo is great. And it doesn't take a long time because a younger surgeon comes with another robo which is of the next generation, and then where is your standing? So we should be careful of where we place ourselves with the patient on technology. Second is, technology will overcome the advantage of many years of experience. Now, a patient like this used to be a delight in every arthroplasty conference on what will be your technique, how much will you cut, what will be your release, everything. But with the technology and the robo coming up, it equalizes the planning and the decision making between the senior most surgeon and the junior most surgeon, and this is going to actually equalize years of training. Even in difficult spine surgeries, this surgery to put in pedicle screws at different levels here will need a very senior spine surgeon. Years of training was required, but with all these technology of robo coming up, pre-planning, and you can see that the robo actually accurately takes you to the trajectories, and this can be done. Now, if you have this technology, there is no big difference of who is the surgeon. Is it the senior most surgeon with 35 years of experience, or it is a reasonably experienced surgeon of just 5 to 10 years? Both can do it very accurately, and this allows them to delve to the most important and surgery. And so, over a period of time, as we start promoting technology, we have to realize that the patient may think that robo is the best surgeon and the robo will be the preferred surgeon in the hospital. Now, right now, we need this cable between the surgeon and the console. But if you replace this cable with Wi-Fi, then a surgeon from London or Cleveland can operate in your hospital, and the person who is going to be there has to be. So even that there can be a surgery in space, the future of robotic telesurgery. So you have to realize that competitions and change are going to be on larger platforms, and we run the risk that the surgeon will become a small part of the whole process. The medical team of future may be of more technical specialists with one supervising surgeon, a data analyst, a system specialist, robo and AI specialist, etc. And your group practice may not be with the other surgeons. Your group practice may be with an engineer, a robo industrialist, and a data specialist, and an analytics person. So this is all going to change, and so brings the question, with so much change, what is the place and the future of the surgeons? Is it going to be really bad? So the answer is what you want to be. That's very important. Now, if you want to be a gatekeeper, entrepreneur, corporate instrument, and case manager, then you are becoming smaller and smaller. If you think yourself that you can hide behind technology, promote yourself behind technology, then you will end up as one of these. But if we don't forget for what purpose medicine was started, if we don't forget that our purpose is to be a healer first, a friend and a confidant to the patient and his family, and a trusted clinical advice, no artificial intelligence or nothing can actually fall in. So for the young person, I would like to say, for all the technology, the backbone of orthopedic surgery is very clinical. Where does patient's dissatisfaction comes from? Patient's dissatisfaction comes from when you don't examine him and communicate to him well. Imaging does not give a clinical diagnosis. For example, this patient was referred to us with instability of gait and also large for lumbar decompression surgery. But just one clinical examination showed that he had an extensor response, and then a CT scan and the MRI at higher level showed actually there was a large OPLL there. I mean, if you had just gone in by other imaging, you would have gone. We should not forget the age-old wisdom in the word, a pound of meticulous clinical examination is worth a ton of investigation of information. So please don't forget this systematic approach. This gives a lot of comfort and strength to the patient. If you forget this, you don't examine it, and you give more importance to the MRI rather than clinical finding. We cannot blame the patient that the patient comes and with a big bunch of MRI and puts it in your hand because he thinks MRI is more superior to you. And this will be a problem, the diagnosis will go, and as young surgeons, we should not put the cart before the horse. Talk to the patient, get a good patient-doctor relationship, become his confidant, and then send him for the take time to talk to the patient and listen to this thing because he will tell you his diagnosis. But do we do it? A study published in the Journal of General Internal Medicine showed that doctors only spend just 11 seconds listening before they interrupt him with an impatient question. Now, this is documented. Now, you have to talk to the patient because it builds a strong relationship, and I'll tell you a true story. Now, in England, when you change your counties, you have to refer to another different hospital. So this is reported in the National Medical Journal then. A lady was transferred from Liverpool to Devonshire because her husband died and she moved to her son, and she was referred to that general hospital. She has had an abdominal surgery 3 months before, and she went in for a checkup. X-ray was done, and they found a needle inside. And you see, if you have a needle left inside, you can get just $1 million. It's indisputable. So you can easily get $1 million. So the current consultant surgeon actually told the lady, I'm afraid that there is something I have to tell you. A needle has been left inside. I am almost sure that it is not going to give you any problem, but due to medical issues, we have to remove it. And she said, okay, I will agree to whatever you say. Only on one condition, you must not let my previous surgeon know that he left a needle inside. And I don't want any medical legal issues with it because he is one of the finest human beings I have ever seen. I have never seen a doctor who has been so kind. He used to talk to me every day, hold my hands. He was more genuinely concerned with me than any of my family members. He will be completely devastated if he knows that this complication happened. So I will accept for anything only if there is no medical legal issues. Otherwise, I am quite happy to have the needle inside. So you see, we blame patients, we talk ill of patients, but if you are able to get their affection, if you are able to build a good relationship, and that relationship could be actually formed only by talking to them. Form good protocols, make sure that even if you attend a workshop or a lunch workshop, that you have enough competency to go back. Whatever you see and hear in conferences does not give you the capacity and capability to go and operate. Because you need to develop a professional competence because we are operating on a patient who is a husband, mother, wife, son or father to someone. And if you have a procedure that is doing well in your hands, think many, many times before changing to a more costly, more instrumental and more challenging and unproven. Because our favorite operation may not be the best one for the patient. As Augustus Soventel, the biggest challenge in medicine is to avoid the attraction for the latest, costliest and most interventional procedure. For example, this is a fracture which in the West is treated like this. It is the most challenging. You can be more interventional, but we all know a simple posterior operation like this is good enough. Less costly, less interventional and very, very low this thing. So we always say treat the patient as your own relative, and then the patient also will think of you as his relative. But easily said then and then. I have put this slide many times before. So, in 1998, there was a main surgical conference where for a listhesis, 360-degree fusion was the main standard of treatment. You had to operate anteriorly and posteriorly. So Alf Nakamson asked everybody, what is the treatment for a 40-year-old person who has occasional back pain? And 94% voted for surgery. He then said, this is your wife's X-ray. How many of you would operate on your wife? From 94%, it fell down to 34%. And then he said, this is your own X-ray. How many of you would have a 360 degrees fusion? It became only 4%. It just shows how much we are biased towards surgery. So even if it is a small cut, it is not correct if you are doing an uneven surgery. So a good example is this patient, just myelopathy, no myelopathy, just occasional axial pain, underwent 3-level disc replacement, developed neurological deficit, underwent a posterior surgery, and then became completely wheelchair. Totally unnecessary surgeries, and it is documented that 30% of all procedures and investigations done across all specialties are unnecessary. Maintain a healthy arms industry with the industry. This is going to be a challenge for all young surgeons because the industry is there to attract you on every. You have to have the industry for academics, but not anything more. There are many innovations which are promoted by the industry. And this is the natural history of new devices. It all comes, and after a few years, you find that there is a big flop. So in this 5 to 10 years, it is always better to stay behind the modern times so that you don't cause more harm to the patients. Taking the example of the disc disease, you can see there is nothing that we have not done to the disc. We have thermalized, we have magnetized, we have injected medicines, we have injected enzymes. And at the end, with all these, the outcomes are often no better than conservative treatment. So in the big change, where the industry is trying to make orthopedics into an orthopedic market, patients as customers and consumers, surgeons will become industry partners, and balance sheets, you have to be careful that you don't fall into this change. If you do, then this will be the problem. As the Indian Medical Association reported, 75% of doctors face verbal or physical abuse, and violence was the most common cause of stress for 43% of doctors. I am not sure whether this high number is really true, but it is published. But I can confidently say that, as it was told during the introduction, we have more than 150,000 patients coming to the hospital, never faced one instance of verbal abuse or violence in our hospital. I think the main important thing is that we always teach all young surgeons, take time to talk to the patient and make sure that you don't jump into conclusions without counseling them very well. This change is for our own peace and happiness. Now, I think the most important thing is that we have to relearn. As Alvin Toffler said, the illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. So we learned to move away from just medicine as a pure art, and we brought evidence-based medicine. But now it is time to relearn and bring back art into the way we practice and understand our patients. So we all know that this is the symbol of medicine. It means that in service of the sick, we must be as wise as the serpents, but actually harmless and soft as the doves. Now, we don't need to worry about mechanization. We don't need to worry about technology. We don't need to worry about artificial intelligence, because if we realize that they all can treat the disease, but it is only physicians who can treat the patient who has the disease. If we understood and we also look at them very clearly, we'll know that any improvement in technology, any advance in artificial intelligence, any change that comes in medicines cannot displace us. Because the surgeon has an undisputed place as a guide, as a true friend, as a healer, and as a mentor to his juniors. And in these areas, there will always be a meaningful and worthful space for the surgeon and the doctor. So let me thank again for this wonderful opportunity to be here, and thank you very much for this order. Thank you very much.
Thank you, sir. Excellent message given to us. So, what was the medical practice earlier, and how it has changed to the position what now we have, and how we had to change and how we had to face accordingly. And thank you so much. And this is the time to felicitate you on behalf of TOSA and TOSACON. Thank you.
It is an immense privilege to introduce the next oration on the name of Professor Paravastu Rangachari sir. So he is known for his groundbreaking work, unwavering dedication and commitment towards orthopedics, especially in Telangana and India. So Professor Paravastu Rangachari sir, born in 1927, Dr. Rangachari finished his schooling in Vijayanagaram and came to Visakhapatnam for his BSc in 1948. Initially, he was interested to become a pilot, and he was forced to apply for an MBBS seat in the combined Madras state by his cousin, noted scientist Dr. Samavedam Sriramachari, a former director ICMR and founder director of Institute of Pathology ICMR, who investigated Bhopal gas tragedy. He completed his MBBS in 1953 from Andhra Medical College, Visakhapatnam. Rangachari Garu used to tell everyone how he was trained in MBBS by able gurus who taught many precise clinical skills that helped him master. In those days, it would take months to get an X-ray done, and so they were taught how to examine and rectify at the earliest. He also worked in the Department of Gynecology initially and started his government service where he went village to village to treat patients. When cholera was much prevalent, he learned how to treat by giving drip with pure coconut water in remote villages. Having a great passion towards engineering, He chose orthopedics under the able guidance of Professor Dr. Rajasekharan garu and completed it in year 1962 with gold medal. Under his guidance, he learnt so many techniques and art of close reduction. He had a wonderful art of putting gypsona plaster in a very classic way, as told by his students who are teachers to most of us here. Dr. Rangachari garu assisted Dr. Vagreshwar garu in many difficult and complicated polio deformity corrections and helped to publish papers. Photography was one of his favorite hobby, which helped him to take photos and prepare slides for paper presentations and teaching. He started his teaching profession in Rangaraya Medical College as a lecturer and head of the department. He was indeed a very good teacher and explains the subject from the basics with good drawings and photographs, drawing 100% attendance in his classes. In the year 1967, Dr. Rangachari garu working in Kakinada applied for FRACS under Colombo plan and went to Melbourne, Australia. He worked along with Dr. Henry Vermont Kroc on vascular supply of bones of hand and wrist. In the second half of 1977, he went to Melbourne, Australia again to do research work on venous drainage of upper end of femur and also got trained in spinal surgery. His work along with Dr. H.V. Kroc and their research paper in the form of a book is placed in Royal Albert Hall, London. As he returned to India, he worked at Andhra Medical College and Usmania Medical College, where he trained many postgraduates. He continued as Professor Emeritus at OMC post-retirement. The best part of all the doctors who worked under him was that they always got motivated to try new techniques and methods and stood by him at all times and presented them in various national platforms. He published more than 35 papers in international and national journals. He was also elected as fellow at FAMS in 1968, FAASC in 1970, and FASI in 1989. In the year 1981, took voluntary retirement from AP government and went to Jamaica as he was invited to set up an orthopedic department there in Montego Bay. In 1986, as he returned to Hyderabad, he joined Deccan Medical College until 2002 as head of the department, where he continued to inspire many students and treat complex cases. He continued to practice until 2018, treating and training many students. In 2018, Dr. Rangachari garu totally stopped practice and was actively involved in writing book on management of different type of fractures along with self-drawn drawings. So now I request one of the disciples of Professor Paravastu Rangachari sir, our beloved V.S. Ravindranathan sir, to come on stage to give an oration on his name.